Okay, good afternoon, everyone. This is the free paper session for congenital heart surgery and congenital heart disease. Today we have only 5 presentations in this afternoon because the first and the 7th presenter don't show up. And so I will start with the second paper. The second paper is the how to manage tricuspid regurgitation exacerbated by recoarctation of aorta in hypoplastic left heart syndrome. Will be presented by Dr. Yasuyuki Kobayashi from Japan. Dr. Yasuyuki, please.
Thank you. No disclosure. Some children cannot achieve full-time saturation because of the right ventricular dysfunction, tricuspid regurgitation, or pulmonary artery environment. Main cause of TR might be structural valve degeneration, recoarctation by aorta provoking afterward mismatch, or unprotected RVPA conduit inducing overload. In adult cardiac area, a study about functional mitral regurgitation and aortic valve stenosis was reported. According to this paper, there are some risk factors like functional mitral regurgitation more than mild and dilated left atrial diameter and the low pressure gradient and the atrial fibrillation. So the patient with these risk factors are recommended to have the mitral valvoplasty in addition to aortic valve replacement. However, in this congenital cardiac area, it is still controversial whether tricuspid valve repair is added to arch repair at stage 2, because the just bidirectional Gren procedure can reduce the volume overload of the right ventricle. So our objective of this study is to track tricuspid valve competence and cardiac performance at stage 2 and stage 3, and to clarify whether tricuspid valve competence is improved by arch repair. Since January 2007 to December 2015, 47 patients with hypoplastic left heart syndrome underwent a bidirectional Gren procedure, subsequently to modify node procedure at our hospital. So 62 patients with HLHS and 4 patients who had a node plus bidirectional Gren procedure are excluded. So 58 patients had node procedure and 7 patients died interstage. So 51 patients had a bidirectional Gren procedure. 47 patients survived, and among 47 patients, 11 patients originally had tricuspid regurgitation at birth, and the other 36 patients did not have tricuspid regurgitation. So these 36 patients did not have tricuspid regurgitation. So what is so these patients that did not have any structural valve degeneration like perforation and prolapse or dysplastic leaflet. And after they had a node procedure, 21 patients did not have tricuspid regurgitation. However, 15 patients has a tricuspid regurgitation. So what is the difference? Recoarctation of aortic arch associated more often in TR group, 0 versus 13, and QP by QS was higher in TR group, 0.54 versus 0.87, and the RV ejection fraction was more decreased in TR group, and endodiastolic pressure was higher in TR group. So you can see that 30 patients had arch repair because of the recoarctation, and the other 2 patients did not have any recoarctation, but their QP by QS was very high, like 1.2 or 1.5. So maybe the TR exacerbated because of the unprotected RVPA conduit. So 30 patients had arch repair in addition to the bidirectional Gren procedure. They didn't have any tricuspid valvoplasty, just arch repair and bidirectional Gren. After they had the operation, 7 patients did not have TR. However, 6 patients remained at TR. So let's compare the 2 groups. that tricuspid annulus at birth did not differ in two groups. However, before bidirectional gram, both groups of the tricuspid annulus was larger, and especially the group R, 131% and 142% of normal. And after they had a bidirectional gram procedure, because of the volume reduction, the tricuspid annulus decreased in both groups. However, the in group R is still higher, 119 and 134. And the RV endodiastolic volume measured before Fontan is still larger in group R. And therefore, ejection fraction was more decreased, and endodiastolic pressure and the pulmonary artery pressure was higher. So TR associating with recoarctation can be basically relieved with just RGPR in addition to bidirectional gram. However, TR proceeding annular dilatation may be difficult to be relieved only by RGPR. Persistent TR until Fontan can exacerbate the right ventricular function like elevation of RV and diastolic pressure and pulmonary artery pressure. Therefore, TR associating with annular dilatation is needed to be repaired in order to protect RV function. Thank you.
Oh, thank you very much for your excellent presentation and excellent outcome. Is there any question or comment from the floor, from the audience? Okay, yes, please. Dr. Chung from Vietnam.
So, what technique you use to repair the arch, especially when you have a recoarctation after not operation? Because as we know that you use in your institution you use the direct PA to the arch reconstruction. So what technique you use for arch reconstruction, especially when the patient have a recoarctation?
So the patchplasty.
Patch.
Yeah.
Arthroplasty.
And
thank you.
Okay, yes, please. Is there any question? Okay, can I ask you, what is the approach that you use to redo the arch repair? I mean, you have the recoarctation, and then you go back in. What kind of approach to do the re-sternotomy or on the left-hand side?
In most cases, median approach.
Okay,
yeah.
median approach.
Again.
Okay.
Yeah.
Okay, so is there any question? Okay, so let's move on. Thank you very much.
Thank you.
Thank you. Okay, so let's move on to the next presentation. It is the transposition of great arteries with intact ventricular septum. What is optimal timing for arterial switch operation will be presented by Dr. Chung from Vietnam. And Dr. Chung, please.
Thank you, Pierre. So I would like to talk about the arterial switch operation and what is the optimal term for TGA IVS experience in my institution. I have no disclosure. So as we might know that the one of the risk factor for ASO is the our age or lead referral of the transposition. So according to the pediatric health information system database, the risk factor of one of the risk factor associated with the higher mortality is the age more than 6 days old. And older age of arterial switch operation associated with higher mortality risk, and the late hospital median age arterial suture operation was associated with higher odds of mortality, longer length of stay, and higher costs. The other paper from Michigan group from Dr. Edward Bovey suggests that the patient presented late than 4 weeks associated with the increase the hospital mortality. This paper also suggests that the patient associated with higher mortality and morbidity, especially if the patient if the arterial suture operation was performed beyond 3 days old. However, in the other paper from especially from developing country, there is no difference between the group with the late referral transposition. And this paper from IGN from Malaysia, they said that there is no difference between the patient older than 30 days old compared to the lesser 30 days old. This paper from Fuwai Children's Hospital from China, there is no difference between the older. They conclude that the overall outcome of arterial suture operation for the patient beyond 1 month is satisfactory, but there is no data for the group less than 30 days old. This is the paper from developed country in Great Ormond Street. So they show that the primary ASO is comparable between 2 groups. The late referral group, the cutoff point is 3 weeks. 3 weeks old. So in the other paper, they conclude that the patient is between 2 groups is the same, have the same result, and the primary arterial suture operation can perform safely even beyond age 2 months. So in our cohort, recently we have 149 patients with TCA IVS underwent primary ASO in our institution. The median age was about 12 days. We have 2 groups. The group less than 30 days old was 93. And the other group is more than 30 days old, which include 56 patients. The median weight is about 3 kilograms. And this is the technique how we use for the ISO. This is the boy, 13 days old, with TGA VSD. I'm sorry, especially and left ventricle outflow tract obstruction with tricuspid, accessory tricuspid tissue. So we perform standard bypass. How to control it? Standard bypass with bicarbonate cannulation. Sorry, so I don't know. I cannot use to move the video faster.
You want to move?
No.
Faster.
Oh, faster. So I cannot control the video. So it takes too long. Sorry. So we perform standard bypass and with bicameral cannulation. And the left vent always uses. The PDA was ligated after bypass starting. So through the left vent, we always push the LA valve, the LA pressure to monitor after operation. So the ascending aorta was transected, and secondary the PDA was transected, and the main PA was transected nearby the bifurcation, and we dissected further to the hilum to perform local maneuver, and the accessory tricuspid van tissue was removed through the to the pulmonary valve, and then we checked the anatomy of the commissure, making a marker stitch, and then perform local maneuver. In this case, there is a single right coronary artery, and there is an intramural coronary artery of the left coronary artery. Here you can see the small ostium of the LCA, and we take down the commissure and make sure that there is where is the end of the comes out of the LCA by coronary probe, and then we create a single button. We create a single coronary button, and then the anterior wall of the intramural coronary artery was totally harvested, removed until the end of the intramural crosses. And then we can easily divide by two separate coronary buttons. So in our cohort, recently we have up to 25 cases of intramural coronary artery, and all of them was successfully divided by two separate by individual coronary buttons. And then we remove the arterial clamp, finding the appropriate position for the coronary reimplantation. And we use a modified trapdoor with a small wing to minimize the possibility of the aortic regurgitation in the long term. And the new PA was reconstructed by autologous, fresh autologous pericardium. So we closed the VSD through the tricuspid valve by interrupted platelet suture. I'm sorry because I cannot control the time of the video, so it's take a little bit long. And then the closed atrium and the distal PA was anastomosed during beating heart. So at the final of the operation. So during this study, we have two patients require airway training, and there is only one patient with a coarctation of the aorta. Most of the patients have the aorta anterior to the right of the PA. Most of the patients have a normal coronary distribution, and there is about almost 20 patients with a single coronary artery, and 8 cases with the intramural coronary artery. So the mean of the arterial clamp time was almost 2 hours, and recently dropped up to 70 minutes I'm sorry, 100, almost 2 hours, and recently it dropped up to 70 minutes. The bypass time is about 170 minutes. So there is a 4 patient require re-exploration during the surgery. And the ventilation time was about 100, more than 100 hours. The main complication in our cohort was pneumonia and sepsis and wound infection. This is the kind of the main complication in, especially in the developing country. There is 2 cases require ECMO. 1 case after intramural coronary artery repair, and 1 case with the LV decompression after surgery. Both of them was recovered very well. So the mortality between 2 groups is not different, but the operation time, bypass time, arterial clamp time, and sternum open is significant different between groups. By logistic multivariable logistic regression, so the infection, the nosocomial infection is the risk for mortality, and there is no difference between 2 groups. With the long-term survival in this cohort was 91%, and no patient require reoperation. By conclusion, the ISO for TGA could be extended beyond 1 month, but the upper optimal age is not yet defined, and there is no difference between groups, including mortality and morbidity. And eliminate nosocomial infection may reduce the in-hospital mortality and morbidity in our institution. Thank you.
Thank you very much, Dr. Chung. Is there any comment or questions from the audience, please? Please, yes. Please identify yourself and okay.
Yeah.
The third question is what kind of cardioplegia solution that you choose?
So we use custodian.
All the case?
Yeah, in one cases.
And there were 8 patients with intramural cause, intramural coronary artery.
Mm-hmm.
Which technique do you prefer? I mean, in the textbook they said you have to cut the intramural part to make it longer. But have you ever mentioned about it?
So you create 2 separate buttons,
yeah,
or use the flip over technique?
No,
to do with
I never use the hood technique. Never ever.
Okay, so
we always separate the intramural coronary by 2 individual coronary button. We always can do it.
And the third question is, when you repair the neo-PA, well, you cut the phrase polycardium in square
rectangular.
shape.
Yeah, it's square.
Yeah.
And stay the commissure high and fix with the predicate, or just without
Okay,
predicate.
so how you fix the pillar, right?
Yes.
Yeah, the aortic valve pillar.
Aortic valve.
Yeah, the posterior, pulmonary valve pillar.
Oh, so we just need 8-hour stitch to fix the commissure to the autologous pericardium patch. So no need for the platelet support.
Thank you.
Yeah,
Thank you.
Thank you.
Congratulations. I also use the same technique as you do concerning the pulmonary artery reconstruction using the rectangular pericardial patch.
Yes.
Okay, thank you.
Thank you.
Yes, please.
Thank you for your excellent operation. I'm Yasuki Kobayashi from Okayama, Japan. I have two questions. First, why is the close clamp time differ in two groups? And second question, did you follow the left ventricular function in the groups with more than 30 days?
For the first question, because the difference between two groups is the arctic cross clamp time is longer than 30 days old, because actually I don't know exactly the main cause. It's just the number, okay. And maybe there is we do not check closely, but it might happen in the first during the learning curve. The most of the patient we do is the older, and recently the fetal echo and earlier diagnosis is much better compared to the previous. So it might be to explain why the cross clamp time in the group more than 30 days old is longer. And how about the second question?
Did you follow the left ventricular function in groups who had the operation more than 30 days?
You mean the ventricular function?
Yes, yes.
Actually, we do not have a data to check the ventricular function in the post-operative care.
Okay, thank you.
Sorry.
Okay, thank you. Okay, Professor Tawa, please.
I have a couple of questions and comments.
Yeah.
I actually did not understand that in patients more than 30 years of age, what was your criteria for not performing an arterial operation? You have done it in a number of patients, but how did you exclude patients towards the other path? Did you prepare the ventricles? On what factors you were looking for before performing an arterial switch operation? So what was the most important thing you determined that you can go ahead with an arterial switch operation in older patients?
Can you repeat the question a little bit slowly, okay. Because I do not understand clearly what you're meaning.
The patient is more than 30 days of age.
Yes.
Still, it has undergone an arterial switch operation. Yeah. So what were the factors which you saw on echo, which you thought the patient is going to accept an arterial switch operation?
Okay, so we decide on the echo imaging. And if the patient do not have a banana shape of the LV, and especially the posterior wall of the LV is more than 3 millimeter, so we go ahead to do the primary ISO.
In my experience, these are very crude indicators. The shape of the LV and the left ventricular posterior wall thickness, even the LV mass. So in my experience, I have observed that if the interventricular septum is moving in the left ventricle, then invariably the patient is going to accept an arterial switch operation. And that is actually up to 3 months of age. You can safely do an arterial switch operation. Now, whenever the patient becomes more than 3 months of age, at that time, even if the septum is moving with the left ventricle, it is going to accept an arterial switch operation. Yeah. And otherwise we just do them on the ECMO circuit, and maybe after 2 to 3 days of this switch operation, the ventricle gets prepared. And secondly, I am very much, I do not know the reason for such a high aortic cross clamp time and operating time. That's pretty high. And also I do not understand the use of the custodial in these patients, because the clamp time for a switch should not be exceeding more than 70 or 75 minutes. So in my experience, a single dose of delnidocardioplegia works very well. And usually the clamp time is something around 35 minutes to 45 minutes, and the bypass time is around 90 minutes or so. The second thing which I do not understand from your presentation is the number of patients which had a VSD. Because if these patients have a VSD, then it is very unlikely that the ventricle is going to be regressed.
Actually, there is no VSD in
Okay,
this cohort. So there is no we in this cohort there is only TGA and intact ventricle septum marrow.
The other thing which I did not observe was your technique of, like you said, the coronary transfer. But I'm sure that many of these patients would have the right coronary artery coming from the LAD. So that actually makes the reconstruction of the RVOT very difficult. So you have to first do the reconstruction of the RVOT and then implant the coronaries. Because if you have done the coronary implantation first and then do the RVT, your suturing is very close to the coronary artery and you can have problems. And also in those patients, you have to close off the LPA and you have to extend your incision into the right pulmonary artery and shift the entire RVT to the right side, so that the right coronary artery is not compressed. I do not know whether you have done that in any of these patients. And the other technique to manage the intramural coronary is, because sometimes it's very difficult to separate two buttons. So you can suture the aorta and the pulmonary together after making a slit, and then you can use a pericardial hood so that the left coronary is perfused. That way you do not need to open the two buttons and extend the incision into intramural. That is one of the things. Secondly, what I have also observed is it is not a good idea to mobilize the coronaries too much, because the blood supply to the coronary, it comes via the vasa vasorum of the coronary artery. So if you dissect too much to get the mobility, then actually you are compromising the arterial supply to the coronary artery, which can lead to long-term stenosis. The third thing is, when you implant the coronary, it should be above the sinus, because otherwise what you're going to get is you're going to get the aortic regurgitation. So it should be implanted higher up, and in case of the abnormal coronaries, when you have the single coronary which you showed and the left coronary rises from the right sinus, then the button should be placed in such a way that the coronary artery do not get kinked. Because what invariably happens is, if your button is not properly implanted, the left coronary artery becomes very lax and the right coronary artery becomes pulled up. So that can create a problem. And like I noticed a very high incidence of arrhythmias, like almost 21% in one group and 14% in the other group. I do not know, as far as my understanding goes, the post-arterial switch, you should not be having the arrhythmia. If your myocardial production is good, and if the coronary transfer is okay, such a high incidence of arrhythmias is not explainable.
Thank you.
Thank you very much. Okay, so let's move on to the third presentation. It is selective approach and procedures for repair of coarctation of the aorta. This presentation will be presented by Dr. Kentaro Hotota. Yes, okay. Dr. Kentaro, please.
Good evening, everybody. I'm presenting about selective approach and procedure for repair of coarctation of the aorta. You have no COI disclosure. Approach and procedure for repair of the coarctation of the aorta were selected individually. When the aortic arch is hypoplastic, we often choose a median sternotomy. Consensus has been gained about this point. But how small is aortic arch hypoplastic? The borderline has not been defined. So the purpose is to assess if our principle is acceptable. Our principle is that the first choice is left thoracotomy unless the concomitant procedure is needed. The anastomosis was made without cutting into the distal arch. This way is a good indication for a long distal arch. We anastomose the aorta without cutting into the minor curvature of the distal transverse arch. We incise into subclavian artery, artery like this, instead to keep larger anastomosis site. If the aortic isthmus is long and long approximation is necessary to anastomose, this tubular augmentation is a good indication for this shape. And the second choice is a median sternotomy if cardiopulmonary bypass is needed for, and distal arch is hypoplastic. This shows methods. Our consecutive 44 patients were included and divided into two groups. 25 patients repaired by left thoracotomy were into group left. 90 patients repaired by median sternotomy were into group mid. By ventricular anatomy was excluded. This shows the patient's characteristics. Age at operation was significantly older in group left than group mid, but weight and height were not different. This figure shows the proportion of procedure in group mid. Most cases were repaired with extended end-to-end anastomosis via median sternotomy. This figure shows the proportion of procedure in group left via thoracotomy. Various procedures were performed depending on the shape around coarctation. I will explain each procedure in order. When the distal arch is not hypoplastic, we do end-to-end anastomosis as a right schema. We also often extend the incision to left subclavian artery, but not into the distal arch as a left schema. This shows post-operative angiography. You can see smooth minor curvature of the distal arch. Next, this shows our unique procedure. After subclavian flap isthmus tubular augmentation, end-to-end anastomosis was made. This shows CT angiography, post-operative CT angiography. Sorry. You can see smooth curvature as well. We had one experience to make a reverse subclavian flap to augment the distal arch like this. We defined a new index to compare. Oh, sorry, this doesn't work well. Sorry. New index to compare the size of the distal arch. We call the TA index. TA index is, sorry. What happened? I don't know. TA index is defined that the diameter of the distal transverse arch is divided by the height, like this. This slide shows the results. No surgical intervention has been required in early and long term after the operation, and no mortality. TA index in group left was significantly bigger than in group mid, but there was no significant difference in the isthmus diameter. Moreover, peak velocity at the distal arch around 1 year after surgery was the same in both groups. The ratio of post-operative balloon angioplasty was also the same. These figures show the difference of the TA index and dispersion and distribution of the TA index. What happened? Please look at the right one. in the pointed two cases, we did only coarctation repair via mid-sternotomy because of the long distal arch, but the TA index was not so small. Encircled dots show the cases with balloon intervention. But smaller TA index is not the reason for needing post-operative intervention in group mid. Next one. Please look at the blue dots. Pointed 3 blue dots show the cases with smaller TA index. The smallest one needed the balloon angioplasty, but there is no significant relationship between the TA index and the frequency of the balloon. In these three cases, pointed 3 cases, we did the procedure without cutting into the distal arch. There is also no significant relationship between the TA index and the incidence of the balloon angioplasty. Discussion. In our study, the patients with TA index of around 5.5 could be repaired by left thoracotomy. Incidence of balloon angioplasty was not associated with type of procedure and TA index. Conclusion, as shown. Thank you. Okay, thank you for listening.
Okay, thank you very much. Okay, is there any discussion or questions from the floor, please? Yes, please. Please identify yourself.
I'm Dr. Huang from National Taiwan University at Taipei. And I can curious for your excellent result, but I think after 30 or 40 years, I start to see the patient with coarctation repair through thoracotomy, which was quite popular in our early years. And if the subclavian artery is sacrificed, the patient looks well, but they start to have subclavian steel syndrome, like brainstem relative ischemia or some problem encountered. So in my experience, I almost always do through median sternotomy without sacrificing the left subclavian artery. So I think your result from median sternotomy to aortic repair is quite excellent, no mortality. And so I think maybe you should not focus on how to select patient to do left thoracotomy. Maybe you should consider to preserve the left subclavian artery, and even if the artery is relatively small. I see my patient operated 30 years ago, left thoracotomy. Everything was fine, but the blood pressure on the left arm could not be measured because of subclavian steel. So I think not only the survival, maybe you should consider it, since your result through sternotomy is quite excellent. So I think maybe you should consider about this topic.
Thank you for your. So it's a very important point. But so our experience is not so long, just 10 years. So unfortunately, our kids has no steel symptoms, but it's one of problem in long term.
Thank you. Dr. Tawa, please.
In our hands, the management strategy is dictated by the anatomy of the patient. Now, the hypoplasia of the arch is a very diffuse term. What actually appears as a small arch to one person, maybe it appears okay for the other person. So if you recall, Roger Mee used to say that if the arch is equal to weight plus 1 millimeter, it will be adequate. It looks small, but it will be adequate, and over a period of time, it will grow. The second thing is, we all think that we should go from the midline to do the arch repair, but there are now a lot of reports in which you can go from the side, you can dissect the whole of the arch, you could put a clamp just distal to the innominate artery and completely take care of the arch from the left thoracotomy. On the other hand, I noticed that you do not have a patient with an intracardiac defect. Now, if you have a patient with an intracardiac defect, then you could manage it in two ways. You could do a left thoracotomy, you could repair the coarctation, then turn the patient over, and then do a sternotomy and go for intracardiac repair. But what I have found very useful, and in the last, I think, 100 cases or so, you do a mid-sternotomy, you do the mobilization of the aorta right up to the descending aorta, you cannulate the patient, don't go on bypass, then put the clamps and do it like a regular coarctation in the arch. After you have done that, then you go on bypass and fix up the intracardiac portion, because that really limits down your bypass time and the clamp time. The other way to repair the coarctation and the small arch in these patients would be you make an incision into the distal arch, go up into the left common carotid artery, slit the left subclavian artery on the top, and join the subclavian artery to the common carotid artery along with the repair of the coarctation. And that augments the distal arch beautifully. So I don't know whether that has been tried in your experience, but if you suture the innominate with the subclavian together and find the distal arch, you can augment very nicely. So these are some of the tricks of the trade which we need to know.
Thank you for your comment. Okay. Thanks. Okay, so I think time's up, and we thank you very much, Dr. Kentaro. Yeah. Let's move on to the next topic. This is the excessive tracheal length in patients with pulmonary artery sling and congenital tracheal stenosis will be presented by Dr. Shu-Chien Huang from Taiwan. And Dr. Huang, please. Thank you.
Thank you, Chairman, dear colleague. And this is a study about a patient with congenital tracheal stenosis. And this is which one? Next slide. We know that the pulmonary sling is frequent associated with congenital tracheal stenosis. And in recent era, slight tracheoplasty is the most popular procedure that we choose to correct the congenital tracheal stenosis. And the slight tracheoplasty, by dividing the trachea and the oblique and the anastomosis, it creates a new diameter of the two times the previous, and the shorten the length by half, and the theoretical the resistance will be 132. And the complete trachea was healed by the native endothelium, so it is the most common procedure provided. However, the trachea was shortened after slight tracheoplasty, and the effect of shortening and the anatomical basis was not well reported in the literature. So in this study, we reviewed our patient who received slight tracheoplasty with the CT scan before and after surgery, and the study included 16 patients with pulmonary sling and 7 patients without pulmonary sling. And our surgical approach is basically through median sternotomy, and if no cardiac defect, we go on partial bypass, divide the pulmonary and do slight tracheoplasty, and then reimplant the pulmonary to the lateral side of main pulmonary. If there was associated cardiac anomaly, we try to correct it in the same time, unless the patient was previously repaired or that diagnosis. This is the figure showed that after cardiopulmonary bypass, we identify the. It didn't work. It didn't work. It didn't work. No work. Okay. And we identify the pulmonary origin from the pulmonary and divide it, and then on the middle figure we mobilize the trachea and then translated the middle. And usually the diameter of trachea is less than 3 millimeters, and then make a anastomosis with absorbed PDS suture. And we use the CT scan to measure the trachea, and we can see that on the left-hand side, the length of trachea we measured in the length of intrathoracic, because in early days we try to decrease the radiation exposure. So we usually do not have the CT scan up to the neck unless specified. And we can see that the length of the trachea and the angle between the left and the right bronchus is, we call it carina angle. And after the surgical repair, we can see on the left-hand side, the trachea is shortened and the angle of carina looks more narrowed. And to correct the size of the different patients, we use the thoracic length. It means the length from T2 to T10 as the reference for the trachea length. And we have studied the tracheal thoracic length. It was relatively constant throughout the patient's age, from the newborn to the adolescent. And the results, and this is male to male, female is almost the same. And the age of observation was, the median was 3.6 months, and the body weight was 4.7 kilos. Most of them have the intubated or ventilator support before surgery. And the bronchial aspiration, the most common is right upper lobe tracheal bronchus. The associate included 16 pulmonary sling and the pulmonary SVC in 6 patients, PDA, VSD, ASD, coarctation, tetraphoto, TA, PVC, and the cardiac cushion at the SERA were also noted. And we show the slide by the trachea length. We can see that on the normal control, the trachea to thoracic ratio is about 3.32. And we can see that the patient with pulmonary artery sling, the trachea length was significantly longer. And we also compare the patient with pulmonary artery sling and without pulmonary artery sling. We can see that if the tracheal stenosis is located at the low trachea, it's quite common in pulmonary sling. And if the patient was without pulmonary sling but also have congenital tracheal stenosis, the patient also have longer trachea, unless the 2 cases with the congenital tracheal stenosis, which was located at the upper trachea part. We can see also the same finding in the patient with the carina angle. We can find that the patient with pulmonary sling and the low tracheal stenosis without pulmonary sling, this two groups looks like the same, but the patient with upper tracheal stenosis seems like different from these 2 groups. So we excluded the two patients for the further analysis, and we compare the patient with the low tracheal stenosis and the normal. And then we can find that after the slight tracheoplasty, the length of trachea was significantly decreased after surgery. This was about 42% decreased to 32% after slight tracheoplasty. And we also compare to the normal control. The normal control is in the green dot. And we can show as the age follow-up, the tracheal thoracic ratio throughout in normal control is relatively constant. And the blue line shows the preoperative. Preoperative, we can see the trachea is significantly longer than the normal control. However, after surgery, the tracheal thoracic ratio looks like near to the normal group. So we think after slight tracheoplasty, the length of trachea was relatively normalized come to the control group. There are similar findings for the carina angle, as we see before surgery, the patient has tracheal stenosis, the carina angle is 120 degrees, and after surgery is about 92 degrees. And it's also hold the same. We compare with the preoperative carina angle and the normal control in the green line. We can see that after before surgery, the tracheal stenosis group have a large angle than the normal, and after surgery, it become the red line. It's almost overlap with the control group. So we think that after the surgery, the length and the carina angle of trachea was normalized. This is the survival curve of our patient. It's about 80% in the long term. Most of the mortality are because of the associated anomaly like multiple anomaly or lead invasion. And so in this study, we can see that usually we can find during the slight trachea process, the trachea was shortened, so both sides of the bronchus was pulled up and the carina angle was narrowed. However, because of the patient natively before surgery, the length of trachea was longer, so slight tracheoplasty could take advantage of the excessive length of the trachea, and then it can maybe benefit for the patient. However, in this study, there are some limitations. The most important is because the congenital trachea is relatively rare, so the case number is still limited. And there are some cases with pulmonary sling but without tracheal stenosis. However, this patient maybe only followed up in the outpatient and did not enter into the study. So I'm not sure the length of trachea is also longer in this group or not. And so in this study, we find that in the patient with congenital tracheal stenosis, especially the low tracheal stenosis with or without pulmonary sling, the trachea was longer and the coronal angle is wider. And this excessive tracheal length is favorable to do a slight tracheoplasty. And so I think in this experience, doing a slight tracheoplasty not only corrects congenital tracheal but also the morphology and the length of the tracheal bronchial tree. Thank you for your attention.
Thank you, Dr. Huang, and congratulations on your excellent outcome. Yes. Any discussions from the floor, please? From the audience? Okay. So thank you very much.
Thank you.
Okay. So this might be the last topic or last presentation for this afternoon. It is the outcome comparison of fenestration and non-fenestration in patients undergoing extracardiac total cardiopulmonary connection, 20-year experience from single tertiary institute. Will be presented by Dr. Chakapan Hosathithikul from Thailand. Dr. Chakapan, please.
Thank you, Mr. Chairman, and good afternoon, everyone. I'm Jakapan Hosathithikul from Chiang Mai University. So let's begin with the background of the study. Firstly, we all know that there are varieties of congenital heart defects, like simple defects and complex ones. And among these diseases, single ventricle physiology is still problematic and remains challenging for surgeons for improving their patients. And in the past, an operation called Fontan or total cavo-pulmonary connection was developed in order to direct the blood directly to the lungs without passing through the ventricle. And it has been known as definitive palliative surgery for cardiac anomalies with univentricular physiology. And later, certain modification techniques were developed, including lateral tunnel and extracardiac Fontan procedures. And of course, extracardiac Fontan had become a preferred technique over decades for several reasons, according to previous evidences. However, patients with Fontan circulation are usually at risk of developing complications associated with increased pulmonary and systemic venous pressure. For this reason, a technique called baffle fenestration was introduced and has been increasingly adopted due to the ability to decrease systemic venous pressure and increase the cardiac output compared to non-fenestration. Nevertheless, the benefits of fenestration for both immediate and long-term post-operative outcomes remain controversial. So the objective of this study is to evaluate short-term and long-term outcomes of fenestration compared to non-fenestration in patients with univentricular physiology undergoing extracardiac Fontan procedures. Now let's move on to methodology. This research is a retrospective cohort study. We enrolled 99 pediatric patients with single ventricle physiology who underwent extracardiac Fontan procedure at Maharaj Nakhon Chiang Mai from 1999 to 2019. Exclusion criteria were those with biventricular physiology, patients who underwent other techniques of Fontan procedures, and those who lost to follow-up and lack of data. After that, the patients were divided into two groups, and fenestration and non-fenestration, and then the data were collected and analyzed respectively. Statistical analysis were done and results were reported as shown. However, since there was a big difference in number of patients in each group, stratified propensity score method was used to analyze the multi-level model data in order to eliminate the bias from covariates. Then long-term survival was analyzed and shown as Kaplan-Meier curve, and the p-value of less than 0.05 was considered statistically significant. Now let's move on to the results. The data were collected in 3 consecutive parts, preoperative, operative, and postoperative. First part is preoperative data. This is the first diagram showing demographic data of the two groups. It shows that the mean age and weight of fenestrated group were significantly lower than the non-fenestrated group, while other preoperative variables remain insignificant, including preoperative oxygen saturation and anatomic subtypes. When comparing the pre-Fontan hemodynamics, including atrial ventricular valve regurgitation, mean pulmonary arterial pressure, and pulmonary vascular resistance and Nakata index, it also shows that there were no significant differences between the two groups. As we move to the operative data, the mean cardiopulmonary bypass time and aortic cross-clamp time of each group were quite similar. But actually, some of the patients were done with beating heart, and those who were we arrested heart is only about the number of patients about 49. For the post-operative data, the early post-operative outcomes are as shown. And our results show that the early post-operative outcomes were not significantly different between the two groups, including the ICU stay, post-operative oxygen saturation, and immediate post-Fontan pressure, and also the major complications. For long-term post-operative complications, the post-operative outcomes, it shows that the fenestrated group has lower long-term mortality than the non-fenestrated group. However, the follow-up time of the fenestrated group was significantly less than the non-fenestrated group. And this is the Kaplan-Meier curve showing less mortality in the fenestrated group. Now we move to see the post-Fontan hemodynamics, including Fontan pressure, aortic valve regurgitation, ventricular function, and long-term complications such as protein-losing enteropathy, cirrhosis, and liver mass. And all of them shows no significant differences between the two groups. However, even if they are not statistically significant, we can still see big differences between incidences of these long-term complications. In other words, I mean that these differences may be clinically significant even though they are not statistically significant. This might be explained by the difference of the post-Fontan pressure between the two groups, which indeed affects long-term outcome. So this is the last table showing the effect of fenestration and non-fenestration on the immediate and long-term outcomes analyzed by multi-level model stratified by propensity score. For immediate outcomes, we can see that there's no differences between the two groups in terms of major complications, the ICU stay, post-operative oxygen saturation, and post-Fontan pressure. In long-term outcomes, despite no statistically significant differences, patients in fenestrated group were less likely to develop liver mass with hazard ratio of 0.34 and have lower long-term mortality compared to those in non-fenestrated group. So we come to a conclusion that neither early nor late post-operative outcomes showed significant differences between non-fenestration and fenestration groups, except for long-term mortality, which was significantly lower in the latter. However, I think that it is still questionable whether slight increased fontan pressure is associated with different incidents of cirrhosis and liver masses or not. So longer follow-up time may be needed as the key for solving this problem. Thank you for your attention.
Thank you, Dr. Chakapan, for your excellent presentation, and also congratulations on the outcome. Okay, Professor Tawa, please.
Presentation. However, I do understand that it's a retrospective cohort study. So it is always difficult to understand the reasons for fenestration in one group and no fenestration in one group. So can you explain a bit about which patients had fenestration and which did not have fenestration?
Okay, thank you for your question. So I think that in the past, in our center, we prefer to do the non-fenestration groups. But later on, during the past 10 years, we prefer doing the fenestration just because that the groups of the patients, there are much more high-risk patients. I mean, the preoperative parameters with atrial ventricular valve regurgitation and the ejection fraction of the patients, and also the pulmonary vascular resistance from preoperative heart cath might be the indicators for choosing fenestration.
So meaning you were doing more high-risk patient in the later part of the experience?
Yes, in our center.
The other thing which actually appeared odd to me was the need for the aortic cross-clamping. In a routine extracardiac fontan, you don't actually need to cross-clamp the aorta. In fact, I do most of my, for the last, I think, 3 or 4 years, I have been doing only off-pump fontans. And if you do a fontan off-pump, then you don't need to fenestrate because you don't have that bypass, you don't have the inflammatory response. So actually, we have published that also. So if you do an off-pump fontan, then you do not need a fenestration. One of the advantages of the fenestration, I would state, which was probably missing in your presentation, was how many of these patients had, the electrophysiologic mapping. Because one of the advantages of the fenestration is the cardiologist can use it for the EP studies on the left side. Otherwise, there's no way to go. You can go via the IVC, you can put a catheter via the fenestration into the left side of the heart, and you can do that mapping. So I think the present day indication of a fenestration would be to have the cardiologist get this facility for an electrophysiologic mapping. The other thing is, like in the present day practice, I would do the fenestration for patients with systemic AVL regurg, with reduced ventricular function, and for the need for PA-plasty. But again, the need for the PA-plasty is something which is problematic. So that, and as far as the cirrhosis of the liver and PLE is concerned, that is really a very, very long-term consequence of the fontan state, and it does not appear immediately. The other thing is you did not mention the size of the fenestration, because that becomes very important.
Yes.
How do you decide the size of the fenestration and the need to close the fenestration?
Okay, so the size of fenestration at our center really varies between the surgeons. But I also collect the data, and the mean size of the fenestration is about 6 millimeters. Yes, but some surgeons decided to do smaller, and some decided just to do 5 to 6 millimeters. And about the patency of the fenestration, we work together with pediatric cardiologists, and they are the ones who perform the post-operative cath and to see the patency of the fenestration. And we actually at our center, when patient already have the fontan circulation, they found that the patency is quite high. I mean, the good patency rate of the fenestration, and no need to do further closure of fenestration or just do more fenestration. Just leave it like that.
That brings us to the question, what was the fenestration size related to the weight of the patient? I think that becomes very important. And then when you cardiologist, like if you have a patient who is desaturating, let's say saturation is around 90 to 95%. So obviously it is because fenestration is shunting right to left. So then what is the policy at your center of occluding the fenestration? Because that is a very important thing.
Yeah. Thank you very much. But can I ask you one question? do you have ever experienced the spontaneous closure of a fenestration?
We do
series?
have patients with spontaneous closure of the fenestration, but those the ones who I collect the data have those who have the spontaneous closure don't have the complications from increased pressure in the fontan circulation.
Yes. Okay. And is there any increase or gradually increase pulmonary artery pressure during the follow-up period of time?
Yeah, but the main findings that we are considering nowadays in our center is the incidence of liver mass and cirrhosis, because about 33 patients that we have a follow-up, about half of them already has the liver mass, and the liver mass that we do the biopsy, it shows that it's focal nodular hyperplasia. So I think there might be some relations with the increased pressure in the.
Were there some patients who were not fenestrated and you had to go ahead and do a fenestration? And if you need to, how? Get my question? A patient did not have a fenestration.
Yeah, the ones who doesn't
and you
have.
need to fenestrate. So how do you do that? And what are your criteria?
First, we will try to do by transcatheter. Yes.
And placement of a stent.
Size of the fenestration.
Usually, what at our center, we first do a CT angio and see how the lie of the graft is with relation to the right atrium, and then you pass a guide wire, you puncture the graft, you go into the atrium, and usually, typically, fenestration alone does not help because it tends to close very fast. So you end up using a 6 millimeter coronary stent, because that will usually keep the fenestration patent. The other thing is, when you go for the closure of the fenestration, the common policy is you go across the fenestration, you occlude the fenestration with a balloon, and then you check for the saturation. Now, if the saturation rises by more than 5% and your cardiac output does not fall, that is the time to close the fenestration.
Yes.
But otherwise, if your cardiac output falls and the patient's saturation is not being affected much, then you should leave the fenestration open. At least, actually, that is a standard guideline which I wanted to highlight. Thank you very much.
Thank you very much for your comment.
Yeah. Is there any comment? And I just would like to call Dr. Kenji Suzuki presenting in this room, because he did not, he hasn't shown up at the to load the slide. Okay. So thank you, Dr. Chakapan. Thank you very much. Okay. So if the last presentation by Dr. Kenji, if he is not here, I would like to close this session. Thank you very much, all the audience. Thank you.